There we go. I'm Marie Wilcock. I'm an advanced practitioner at the Blackpool Lipid Clinic. We started the clinic back in 2019 and it's expanded significantly since that time. We started genetic testing for familial hypercholesterolemia in 2021 once it was funded on the NHS. We are a team that consists of myself, 2 interventional cardiologists and a lead cardiac pharmacist. A large part of my role involves assessment for familial hypercholesterolemia and, if appropriate, genetic testing. And I've been invited here today by the Innovation Agency to discuss it further with you this evening, alongside Joe from Cheshire and Mersey Familial Hypercholesterolemia Service. So, apologies. So, what is FH? Which I will refer to as FH from here on in, because familial hypercholesterolemia is a bit of a mouthful. It is an autosomal dominant lipid disorder which exposes an individual to a lifelong exposure of raised levels of LDL cholesterol and therefore at risk of premature cardiovascular events. As it is a dominant genetic disorder, any offspring of an affected patient has a 50% chance of also inheriting that variant, and it affects all races and ethnic groups. So we cannot cure FH, but detection and reduction in LDL levels of cholesterol is the next best thing. FH is easy to diagnose and easy to treat, but has remained underdiagnosed and undertreated for a long period of time. And we'll look into the reasons of this a bit further on. The risk of not treating people with FH can lead to 50% of males suffering an MI prior to the age of 50 and 30% of females prior to the age of 60, which, when we look at prevalence a bit further on, equates to a large number of patients suffering from premature events. Most individuals with FH have one disease-causing variant, causing heterozygous FH. Rarely people inherit 2 disease-causing variants in the same gene, causing homozygous FH, or they may inherit a combination of disease-causing variants in 2 different genes, causing compound heterozygous FH. Although these patients generally present clinically like homozygous patients and should be diagnosed and treated as such. So looking at the prevalence of this condition, FH is one of the most common inherited disorders. Prevalence varies in different populations throughout the world. In some subpopulations, there is a higher incidence of more than 1 in 100 due to the founder effect, whereas small populations have grown not by recruiting new members, but marrying within their own community. And this also increases the likelihood of cases of homozygous FH. Prevalence also varies across the UK, but nationally, heterozygous FH is estimated at approximately 1 in 250. This equates to over 270,000 cases in the UK. 50,000 of these are expected to be children. Homozygous FH is a lot rarer, and initially thought to be literally 1 in a million chance has now been estimated about 1 in 250,000. Like I said, it is a lot rarer but has terrible consequences, as premature coronary heart disease can develop very early, resulting in an event in the first decade of life. Detection is important, as we have just heard, it is a very common condition. Historically, you may have only discovered that a patient has possible FH after a premature cardiovascular event. It can be devastating for families, and I believe that Joe will be looking at a family pedigree later in the presentation. But you can see when these are drawn out, families trapped in a cycle of premature coronary heart disease. There is also the financial burden to the NHS. We already know that CVD costs the NHS approximately £7.5 billion annually in England alone, with the wider economic cost being estimated at double that. And FH is contributing to that burden. As stated earlier, it is easy to diagnose and easy to treat, and this is generally using inexpensive therapies. But most importantly, if we can diagnose FH in patients at a young age, there is an enormous potential to prevent the development of coronary heart disease, resulting in a reduction in premature death and also long-term morbidity. A brief look at the history of case finding. So back in 1973, Goldstein and Brown identified a protein they named the LDL receptor and a variation in that gene that interfered with its function, after which time more variations were discovered. Over the following 2 decades, Professor Steve Humphreys with the British Heart Foundation conducting research and proved how effective DNA testing was in finding these variants and diagnosing FH. The British Heart Foundation then invested millions into implementing his findings into clinical practice. They then funded 27 FH nurses across 12 sites in the UK to aid detection of FH. However, despite this, alongside campaigns by Heart UK and Public Health England, it was estimated by 2019 that only 7% of cases have been found. It then became part of the NHS long-term plan to identify 25% of cases by 2024, which is nearly upon us already. This was boosted by the Investment and Impact Fund for the last financial year to incentivise GPs to refer patients to secondary care who they've assessed as having possible FH, which in some areas of the country overwhelmed many lipid clinics. Current estimates for cases found nationally are difficult to assess and vary across the country, but is thought to be currently around 15 to 20%. So where have the difficulties lay? Many health professionals are unaware with familial hypercholesterolemia, hence the importance of platforms like tonight. A lack of awareness of actually how common the condition is. The underestimated risk, as many individuals with FH are young and deemed to be fit and healthy. A previous lack of screening to find individuals with possible FH, and also the existing burden on primary care services. Case finding, along with many other areas of healthcare, was also hugely affected by COVID, and genetic testing on the NHS was actually delayed during this time. Once suspicion of FH has been raised with a patient, healthcare professionals should exclude secondary causes of hypercholesterolemia before a diagnosis of FH can be considered. This list is not exhaustive, but patients should have bloods checked for, sorry, I've skipped on a slide. I'm just going to go back. Apologies for that. So we should be suspecting FH in individuals with total cholesterol greater than 7.5 or with a personal family history of premature coronary heart disease. And if we systematically searching primary care records, we should be looking for patients less than 30 with a total cholesterol greater than 7.5 or people over the age of 30 with a total cholesterol of greater than 9. And for people with a personal or family history of premature coronary heart disease, we should be offering to test their cholesterol levels. So as I just alluded to earlier, as I skip forward, it's about then ruling out secondary causes of hypercholesterolemia. So blood should be taken to check for diabetes, hypothyroidism. Postmenopausal women will have raised cholesterol levels. So if available, checking for historical records prior to menopause, as remember, FH causes a lifelong exposure to raised LDL levels. And other causes such as pregnancy, CKD, or nephrotic syndrome. Also, certain medications can raise levels. So again, it's trying to look at historical levels if they are available. Once secondary causes are ruled out, we should obtain a fasting lipid profile if not already done so. This would provide you with an LDL level, which can then be used to use assessment tools to, again, guide assessment of that patient of possible FH. And we've got the Simon-Broom criteria or the Dutch Lipid Network criteria. Patients should then be referred into specialist services if they score possible or definite FH on the Simon Broom or have a Dutch Lipid Clinic Network score of greater than 5. When a patient is then seen in a specialist service, we check for understanding of why they've been referred, and then they are further assessed with an in-depth review of past medical history, medication history, historical blood results, and also family history. If a patient is then deemed appropriate for genetic testing, this service is explained in full and the patient receives genetic counselling, which includes information about how the results will impact them, both positive and negative, and the possible impact on first-degree relatives. The possible outcomes and also limitations of genetic testing are also explained. If they wish to proceed, they are consented and a blood sample is taken and sent to the local genetic hub, for which there are 7 across the UK currently. The patient, if the first in the family to be genetically tested for FH, are known as the proband case, sometimes referred to as the index case. It is explained that there are no incidental findings and the test is only screening for variants in FH. Results for a proband is usually around 5 to 6 weeks' time. This does vary across the country, with some genetic hubs struggling with staffing and demand. However, I have to say in the Northwest currently, things appear to be running smoothly. And then the patient is followed up with the results. So what are we looking for? FH is caused by variants in certain genes. So the LDLR gene counts for over 90% of positive FH cases, with variants also in the ApoB gene accounting for approximately 5%, and the PCSK9 gene approximately 2% of cases. Much rarer are a variant in ApoE, and also autosomal recessive variant in the LDL-RAP1 gene, which are very rare but are part of the screening panel. Whichever of these genes have been affected, it will affect the body's ability to regulate LDL levels, leading to the rise in those levels. We are aware of thousands of variants. As stated, the majority of these affect the LDLR gene, with each variant causing varying levels in LDL cholesterol. So levels in this group do differ widely. Certain heterozygous variants in this group can have very high levels of LDL cholesterol, which can lead to CHD events prior to adulthood. For patients who have been assessed as possible FH using clinical criteria as having possible FH, 20 to 40% are found to have an FH causing variant. And for those who've been clinically assessed of having definite FH, 60 to 80% of those will be found to have an FH causing variant. DNA testing confirms the diagnosis and is considered gold standard, but is not always necessary, and the benefits of genetic testing should be assessed before genetic testing is carried out. For example, if a patient is already being treated for their hypercholesterolemia and there are no first-degree relatives to offer cascade testing to, there may be no benefits to genetic testing. So looking at the results, in positive cases, the report will show the actual variant on which gene it is. A family pedigree is then drawn out to identify possible members for cascade screening that are at risk. And these are offered through either direct or indirect contact, depending on how the individual patient wishes to proceed. All patients who have received a diagnosis of FH remain under the care of the team with at least an annual review. For those with negative results for an identifiable monogenic cause of their FH, the majority are likely to have polygenic hypercholesterolemia, which is where a patient has a higher than average burden of common small effect LDL raising genetic variants, which accumulate in a raised LDL similar to those with FH, which is deemed a risk factor but not as high risk as familial hypercholesterolemia. Another possible result is a BUS, a variant of unknown significance is where a variant is found in one of the genes causing FH, but there is not enough evidence to classify it as pathogenic or benign. And it kind of sits on a waiting list until further evidence is found, as genetics is progressing all the time, and it may well be reclassified at a later date, which is why genetic hub store samples. There has also been an expansion of the SNOMED codes for primary care. So rather than a code that just states whether it's a negative or a positive test, for those who test positives, there are SNOMED codes for each individual gene that's been affected. Cascade testing is a mechanism for identifying people at risk for this genetic condition using a process of systematically family tracing. For FH, cascade testing of close relatives who carry a 50% risk of the disorder is recommended. It's an extremely cost-effective approach to diagnosing new patients. So in summary, once FH is identified, it can be easily treated, and as stated earlier, is often inexpensive. It can have a devastating effect on families, and genetic testing and the subsequent cascade testing play a crucial part in breaking the cycle of premature coronary heart disease within families. Undetected FH impacts on the financial burden for the NHS. It needs to be a coordinated effort between primary and secondary care, so I've appreciated being here to discuss this with you this evening.